Good evening, everyone. I would like to welcome you to this AbbVie Allergan Symposium. And we have an eminent speaker with us, Dr. Anirudh Agarwal. He's an associate staff physician in vitreoretina and uveitis, and he works at Cleveland Clinic, Abu Dhabi. And I would be glad, and it's an honor to have him as one of our speakers here. And he'll be speaking to us on early switch and treatment of refractory DME from evidence to real world. So the floor is yours, Anirudh.
Thank you, sir. Thank you very much to AbbVie Allergan for this opportunity. Thank you, QIC. And so the topic of discussion for today is the early switch and treatment of refractory DME, and from real world and to the evidence. So these are my disclaimers. So I don't have any financial interests in Allergan or AbbVie. And I'd like to begin with just very basics as far as the evidence of inflammation in DME is concerned. So we all know that retinal damage in diabetes is related to hypoxia and hyperglycemia. And one of the molecules that is of interest to all of us is interleukin 6. This is something which is released by microglia and macrophages, and it causes several downstream, cascade of inflammation, also increasing the VEGF levels in the eye. So it's not only responsible for increase in the angiogenesis, but it also has an inflammatory pathway where it increases molecules such as MCP1 and ICAM, which are responsible for inflammation. Now, it's evident that macular edema is seen in multiple diseases, and we talk about inflammation leading to macular edema in not only diabetes, but also in vein occlusion, of course, uveitis, and also neovascular AMD. So in all of these conditions, we know that inflammatory mechanisms play a major role. And the role of inflammation in the development of DME is also well known. And we know that there is a recruitment of leukocytes, which are releasing the reactive oxygen species and inflammatory cytokines, causing vascular compromise and leakage. And all of this leads to diabetic macular edema. Now, while there are different theories which explain the reasons for DME, we now know it's multifactorial, and it's not just related to the VEGF release, but inflammatory molecules such as IL-6 and IL-8 in particular are very relevant in the pathophysiology of DME. So if you come to the question of optimal treatment of DME, we know we are in the era of personalized medicine, but ideally one treatment would be to address multiple pathways and not just target one molecule, which is VEGF. Since you have so many inflammatory mediators, including VEGF, which are upregulated in DME, a wholesome approach would be to target all of them. And maybe in some patients, you have a subset where certain markers such as ICAM1 or MCP1 are more predominant, whereas in some others, you have VEGF, which is more predominant. This is something which is yet still not very, very clear. And therefore, you have this concept which is coming up of personalized medicine. Now, in order to address this question, in 2014, I was a part of this study in which we analyzed baseline IL-6 levels in the aqueous humor in patients with DME who were undergoing anti-VEGF monotherapy. In fact, this was an application for a research award at Bayer and received a GOP award for this project. And we recruited patients of READ3 trial, which is ranibizumab in DME. It's a phase 2 study which was done in eyes with DME. And the inclusion criteria was simple. There were certain visual acuity criteria and OCT criteria. And in this study, we randomized patients into two arms. One was ranibizumab 0.5 milligram and the other was 2 milligrams. The study endpoint was at 6 months. But what is important in this subset was that we took serial samples from the aqueous humor of 131 eyes. And these were collected at baseline and at various intervals. And what we measured was interleukin 6 levels and of course interleukin 8 levels. The results of this study were very interesting, and we realized that the IL-6 levels through month 12 have certain changes, but what is very important is the baseline interleukin 6 levels. And we realized that there is a negative correlation between the interleukin 6 levels and best corrected visual acuity. So if the baseline interleukin 6 is high, these patients are expected to have a much less visual acuity. So this also can be seen in this particular graph. So those who have less visual acuity gains also have a higher baseline interleukin 6 levels. So definitely interleukin 6 has an important role to play. And elevated levels of interleukin 6 can be detected in ocular fluids, not only of DME, but now we know it happens also in AMD and also in non-infectious uveitis. And baseline IL-6 are not affected by VEGF inhibition. So use of ranibizumab is not going to change these interleukin 6 levels. And there appears to be a trend of lower BCVA gains in eyes with AMD and DME with higher interleukin 6. Now, of course, we cannot measure interleukin 6 levels in all eyes before we start treatment, but this is something that we must keep in mind. Moving on, this has certain implications in our practice. So when we talk about corticosteroids in the management of DME, use of corticosteroids, we all know, may be a more comprehensive approach because it not just targets inflammation, but corticosteroids also target VEGF and they decrease the leakage through the impaired blood retinal barrier and decrease the expression of ICAM1. Not only that, corticosteroids may also target both of these pathways, and the VEGF inhibition will also stabilize the vascular architecture and prevent the leakage, stabilizing or reducing diabetic macular edema. Whereas anti-VEGF agents will act only on one arm of this particular pathway. So the use of corticosteroids in DME may be more comprehensive than anti-VEGF. Of course, it may not be needed for all patients, but especially in patients who are refractory or even in patients who are has certain inflammatory biomarkers at the baseline. For example, they have hyperreflective foci on their OCT, or they have significant amount of subretinal fluid. These are markers of inflammation, and these are patients who may benefit with corticosteroid therapy at the baseline. Now, URETNA recently has recommended that corticosteroids are important in the management of DME, and they have defined anti-VEGF non-responders as those with have no response with less than a 5-letter gain or less than 20% reduction in thickness at 3 months. So they have kept a target of 3 months depending upon the specific response, and this translates to usually 3 injections if we are giving a monthly injection. Whereas the other indications that they recognize are important for corticosteroids are pseudophakic patients, patients with systemic risk factors such as cardiovascular risk factors, and those who are not willing to come so fast, at monthly intervals for injections. Now, the benefits behind the corticosteroid therapy is rapid and sustained reduction in the central retinal thickness. So you can see that there is a rapid and there is a substantial decrease in the central retinal thickness, and this happens in several of our patients. Very few patients are non-responsive to corticosteroid therapy, and even treatment-naive patients can benefit greatly with corticosteroid therapy. And in those eyes, versus patients who are refractory to anti-VEGF treatment. So those patients who are started with Ozurdex and switched from anti-VEGF can also experience these benefits. Now, early treatment with corticosteroid has a potential to improve our visual outcome and reduce edema in treatment naive as well as previously treated patients. So they may experience good gains in the visual acuity. The gain may be even 1 line greater than previously untreated patients. Than those with refractory DME. So you are talking about a substantial improvement, 1 line greater with corticosteroid therapy. Of course, if you do early treatment, this will also translate into better central macular thickness reductions with corticosteroid therapy in treatment naive and previously treated patients. So what we usually do, and I think most of us would like to switch early. We usually do not wait very long before we decide to switch. And in my practice, I do not wait beyond 2 to 3 injections, hoping for a response. And I'll show you some illustrative cases. But real world evidence also shows that patients who respond insufficiently to 3 injections, they can be taken up for corticosteroid therapy. and they will perform better at 1 year than those who are continuing on anti-VEGF therapy. So we believe that if the patients do not respond to 3 injections or respond suboptimally, it's probably time to switch. And this is again observed in the RISE and RIDE trials of ranibizumab, where we realized that patients who did not respond to 3 injections, very few of them actually responded to subsequent injections. And so most of us would not like to wait beyond maybe 2 or 3 injections. We would certainly not like to wait for 6, 7 injections before we decide to switch. Now, switching to Ozurdex early also shows that visual acuity outcomes may be better at 1 year compared to those who continue on anti-VEGF therapy. And we realize that all these patients who receive corticosteroid, one of the important considerations we have is rise in the intraocular pressure and cataract formation. But we now know with corticosteroid, with Ozurdex specifically, that the rise in IOP is quite predictable and usually very, very easily manageable at the most with topical therapy. Very few patients would undergo surgical therapy for secondary or refractory glaucoma which develops, but usually it's a transient rise. And once you have this transient rise, you can treat with topical and then decide if you really want to treat the next time with corticosteroid, or you can consider something else. But very few patients actually undergo treatments for glaucoma in the form of surgery. And the use of IOP lowering medications also, this is, as reported by the MEAD study and the other studies, the clinical trials, is the same thing that we see in clinical practice. We don't see more than 20% patients needing topical therapy, and usually it's a transient therapy. Of course, just to reiterate, the pressure rise with corticosteroid is usually manageable and predictable. And like I said, very few patients end up with surgical therapy for the Ozurdex implants. Of course, we have some patients who are very refractory and they may require even surgical removal of the implant, but these are rare and probably reported in few case reports throughout the world. But certainly that doesn't, avoid or, prevent us from using this particular therapy. Now, the dexamethasone implant, we all know, is a 700 microgram biodegradable implant, and it releases the active ingredient for 4 to 6 months. Typically, we start seeing these patients back with intraretinal or subretinal fluid at 4 months, and we know it's time to probably inject, sooner or later, if at all we have to inject. Now, the consensus on dexamethasone implant in eyes with DME was also by an expert panel from Italian doctors. This was published in 2019 using a Delphi approach. Several Italian retinal specialists, they proposed various guidelines and statements that supported the use of corticosteroids in DME. And we realized that on a lot of aspects, such as refractory DME, pseudophakic patients, or patients with systemic risk factors, it's a no-brainer, but corticosteroids are really, one of the best options in these patients now. Along with cataract surgery, in patients who are undergoing cataract surgery or who've had recent cataract surgery, the mechanism of worsening of DME may be entirely different from a treatment naive DME that you otherwise get in your clinic, because cataract surgery certainly predisposes to a lot of inflammation in the eye. And this is a sort of an Irwin gas syndrome which is developing, typically peaking at 6 weeks in the post-operative period, and can be managed very well using Ozurdex or corticosteroid therapy. And of course, I was a part of a clinical trial pilot study which was published in 2012 in ophthalmology, where we did a pilot trial of 25 patients, and we injected Ozurdex implant along with cataract surgery in the same sitting to prevent worsening of macular edema, and we had sustained results until 12 weeks. And in patients who've had a previous vitrectomy, this is a very important subset of patients. We know that in eyes which are vitrectomized, dexamethasone implant performs very well, and the visual acuity outcomes are quite similar to those who are non-vitrectomized. And so it could be a very useful therapy. So there are certain concerns that, if the eye is vitrectomized, could the injection go really fast? In our clinical practice, we have seen that a gentle injection usually doesn't cause any complications, but some of you may have read that it can actually go really fast and hit the retina on the other side. And so far I have seen only one clinical picture about 1 week ago where this actually happened. But I believe that if you have a patient where you're doing a gentle injection, this is usually not the concern. And it's not this, probably the the device itself, but it's probably related to the technique of injection. So in vitrectomized eyes, uh, uh, corticosteroid implants like Ozurdex perform really well, and the visual acuity outcomes are quite comparable to those without any previous vitrectomy. Retreatments with dexamethasone implant, one of the very useful things we've seen with this agent is a sustained response. So if the patient responds to first injection, they will respond to subsequent injections, and even probably even better. And so you can use a PRN approach. You don't have to have too many studies looking at mandatory treatments versus a PRN approach. With dexamethasone implant, it becomes very simple that you can go ahead with a PRN approach. And in our practice, coming back to switching from anti-VEGF, usually the studies like such as the MEAD study, which have done a subgroup analysis, show that there are benefits from switching. And probably if you have to switch, you would switch after 2 or 3 injections. This was not something which was tested by the MEAD study, but I'll show you subsequently. This is the visual acuity gains, but subsequently we have seen that burden of, you can even reduce the burden of treatment if you're giving an Ozurdex implant after non-refractory response or suboptimal response to anti-VEGF. So the dosing regimen is definitely advantageous. It gives you an improved quality of life. And in patients who have difficulty follow-up, they're coming from far, they cannot visit very often, it's a good idea to probably give them the implant, provided they can get an IOP check locally. And probably if there is some concern, they should have some kind of support. But yes, if they cannot come for a routine full follow-up with an OCT and dilation, then Ozurdex works really well. Now, I'll show you certain very specific case examples where I found the corticosteroid implant very useful. And one of this was a patient with, this is a usual patient of moderate DME, moderate NPDR with DME in the left eye I'm showing you specifically. And you can see the fluorescein angiography shows you leakage from microaneurysms all over. Now, there is no obvious NVE, so this really did not merit mandatory anti-VEGF treatment. You can see that there is a diffuse leakage temporal to the fovea. Now, this patient did receive 3 injections already by the time he came to me in August 2021. And this was the 3rd injection of anti-VEGF I planned. Now, the top image is a horizontal scan. The bottom image is the vertical scan of the same visit. At this visit, I decided to give ranibizumab, and he came back to me in September, and almost the patient was not very satisfied. There is fluid in both the horizontal and the vertical scans. And like all the time, we counsel the patient that probably you'll respond to the 4th or the 5th one. And that was done. However, you can see in November, there is suboptimal response. The visual acuity didn't improve, and some of these cystoid spaces remain. Now, what you can also see is these characteristic hyperreflective foci, which are there in the, in the outer retina, or some of them are even in the inner retina surrounding the cystoid spaces. And these are markers of inflammation. And at this point, again, we did the ranibizumab, but did not work. Now, when this patient comes in December, you can see there are cystoid spaces and there are hyperreflective foci. These hyperreflective foci, they tend to migrate, they tend to change character, but they're still present. And in December, I decided to switch to corticosteroid, and this is probably just 2 weeks after the implant. And you can see the vertical scan and the horizontal scan are dry, quite better. The response is much better to anti-VEGF. And I would probably wait a little longer, repeat OCT, and I'm sure that there would be a sustained response in these patients. What is also noteworthy is the amount of hyperreflective foci also decrease in these patients with time. Now, this leads to a question. Would an earlier switch have resulted in better outcome? Would it have resulted in a more complete resolution of fluid or a better visual outcome? And only we have studies to fall back upon, and the studies definitely suggest that both macular thickness values and visual acuity outcomes are better if switched early. This is a patient who I did vitrectomy for tractional retinal detachment. And this was a complex case, and we had to put gas, and extensive laser was applied. And you can see there are some subretinal bands nasally. This patient did attach in the postoperative period but developed a thick epiretinal membrane. Now, this is a one-eyed monocular patient with no light perception in the other eye. So he was not willing for a second surgery to remove this epiretinal membrane, but at the same time, there is a significant macular edema. And at this point, his visual acuity was 2400. And at this point, I discussed with the patient and I said, we probably can even at least treat the DME. And he agreed to an Ozurdex implant, and we see at least the cystoid spaces have gone away. His visual acuity, it improved to 2200 without the cystoid spaces. And this made the patient at least consider surgery as an option because we could demonstrate that you have a visual potential. And if you take out the epiretinal membrane, maybe you can improve even further. So this gave him a chance to experience better vision. My third case is a patient of CRVO with, now this patient was treated multiple times with injections, anti-VEGF, and this patient developed a very thick, a very sort of very highly hyper-reflective central tissue or an epiretinal membrane right in the foveal center. So, of course, he was bothered by significant metamorphopsia. There is macular edema in cystoid spaces, and so to our minds, we would definitely consider vitreoretinal surgery, and I removed the epiretinal membrane. But at the same time, in these patients, I often do a concomitant corticosteroid injection to take care of the macular edema. So that's what I did. I peeled all the epiretinal membrane and I injected the corticosteroid implant simultaneously. This is how the patient looks at 2 weeks after the surgery. And you could see that the epiretinal membrane is out. There are some residual retinal folds which hopefully settle down, but the macular edema has gone away. And this is the patient at 1 month. At 1 month, you can see the subfoveal hyperreflectivity has improved. The retinal folds will take a little time to settle down, but at least the metamorphopsia is greatly relieved. The visual acuity improved from 2200 to 2080 at this point, and there is no macular edema. So with this, I'd just like to conclude, and I'll state that, so definitely we know that there is a niche of patients, a subgroup, who really benefit greatly with corticosteroid therapy. And especially these are eyes who are pseudophakic, vitrectomized, undergoing surgery, especially cataract surgery or massive DMEs with epiretinal membranes, or even eyes that have undergone surgery for, let's say, tractional retinal detachments. Even treatment naive patients with significant amount of inflammatory markers, we can go ahead with corticosteroid therapy. These are, of course, one of the best treatment options for patients with systemic risk factors such as thromboembolic disease or cardiovascular disease, and in patients who have suboptimal response after 2 or 3 anti-VEGF injections. Thank you very much, and I look forward to questions.
Thank you, Anirudh. That was a very comprehensive talk on Ozurdex in DME. I know you mentioned about IL-6 in one of your slides.
Yes.
So in your research, did you look at the duration of the DME in relation to the levels of IL-6? Was that an option?
Yeah. So in that study, sir, we did the serial analysis of aqueous sample. It was done at baseline, 3 weeks, 6 weeks, 9 weeks, and 12 weeks. And we did not do cytokine analysis beyond 12 weeks, but we realized that there was a trend towards if the baseline IL-6 levels were very high, anti-VEGF therapy had no bearing. It did not decrease the interleukin 6 levels. Whereas the patients who had low IL-6 to begin with, they also remain the same. So there was no statistical change in the IL-6 with anti-VEGF therapy. This just showed something that we know intuitively, that anti-VEGF will not decrease IL-6. Maybe these patients could have done better with corticosteroid implant. And these patients had poor visual outcomes. So it correlated negatively. So I think this is a great research idea where you can compare these interleukin levels 6 and 8 or even other molecules. Now we talk about inflammasomes and we talk about ICAMs and all of these, whether they change comparing anti-VEGF with corticosteroid therapy.
I know you alluded to the indications of using Ozurdex in naive patients, but can you just repeat it for the sake of the audience?
So I usually look at the OCT very carefully when I have a patient of new patient with DME, and I typically decide on corticosteroid implant if I see significant subretinal fluid or a serious macular detachment, and if I see there are signs such as hyperreflective foci, which are plenty distributed in the macula, then I would be tilted in favor of a corticosteroid implant. Not necessarily I can prove it in the literature, but definitely I think they respond better. Some patients who have systemic diseases such as renal failure or renal diseases, or those who have deranged profiles, high creatinine levels, they may also respond better to corticosteroid therapy as a treatment naive compared to anti-VEGF. So I think these are patients who do better. Some patients on pioglitazone do better with corticosteroid implant, even if they're treatment naive.
Even with hard exudates, uh,
Yes, even with
especially
hard exudate.
hard, hard exudates. Yeah, and you did mention about early switching. So as you showed in your, even in your case, as well as the various studies, you generally look at 3 injections. Do you switch from one anti-VEGF to another anti-VEGF and then consider Ozurdex, or would you like to straight away go to Ozurdex, or you feel both the anti-VEGFs works the same?
For DME, I don't particularly see a benefit in shifting from one anti-VEGF to another. It makes me a little uncomfortable to tell the patient that I'm trying a different agent from the same class. So if I'm shifting, I usually am tilted towards giving a different drug like a corticosteroid. But yes, if it's a different indication, let's say it's AMD or PCV, then I might shift from, let's say, ranibizumab to aflibercept, or vice versa. But DME eyes, I think I'm more inclined towards corticosteroid as a preferred agent to switch.
Okay. So I think we are at 10:20.
Yes,
So thank you very much for this excellent talk, Anirudh, and
thank you.
thank
Thank you
you,
for.
thank you everyone for joining. So with this, we shall be concluding our session, the AbbVie and Allergan Symposium. Thank you, and have a
Thank
safe,
you.
yeah, stay safe and take care, and good evening.
Bye.
Bye bye, bye, Anirudh.